This is EHJ Today at the Cardiology Update 2017 in Davos, Switzerland. I'm Editor-in-Chief of the European Heart Journal, and my name is Tom Lüscher, and I sit here with Otto Smiseth from Oslo University. He's a professor of cardiology and head of the heart center there, and world expert in echo. Welcome, Otto.
Thank you very much, Tom. It's a pleasure to be here at this, I would say, extraordinarily fascinating meeting, which is for me a great experience every time. So, and to give a talk on the topic has been a pleasure.
Good. So, echo started with M-mode. When was that roughly?
Well, in 1950s, it was innovated in Sweden at Karolinska.
Actually, they learned from navigation of ships, didn't they?
And Elder and Hertz did that. Mm-hmm. And then in 1976 in Oslo, the researcher Jarle Horn actually was an engineer coming from Boeing in the aircraft industry and knew about the Bernoulli equation. So we simplified the Bernoulli, kicked out some complex term and came up with a simple way to measure pressure gradients.
So that doctors can understand it.
Yeah, that was a great achievement. Yeah. Mm-hmm. Then in the late 1980s and mid-1990s, the tissue Doppler came along.
So what, I mean, with M-mode, of course, we can look at the cavity size, the movement of the mitral valve, the aortic valve, so that was already quite good, and it was, of course, non-invasive. And now we can also look at strain of the ventricle. What does this really bring for the clinician, for a clinical assessment of a patient?
On the road from M-mode to strain, I think important stop on the road was the tissue Doppler. Mm-hmm. The hottest thing now is really strain, because strain is sort of the intrinsic contraction of the myocardium. And if strain could be measured perfectly, you would have the perfect measure. Now we have strain by echo, and it's a good measure, and it is still undergoing development, but it's at the present time it's used quite widely.
So when I do a ejection fraction the traditional way, what do I learn in addition if I measure strain?
For instance, if you have LV hypertrophy, you will have often a very normal or even high ejection fraction, like in cardiomyopathies, and you can still have a reduced function, because when you have a small LV chamber and a thick wall, it will almost close completely, even with a small contraction. So the ejection fraction is good, very good, and still it's the most important measure. But you can get wrong answers if you have a normal ejection fraction with LV hypertrophy, and then strain on top of that can show you in some patients that there's a reduction in systolic function.
Well, that actually has also been shown when you isolate the fibers of these patients, that counterintuitively they're actually reduced in contractility. The other situation we discussed just with Alec Vanian a minute ago was mitral regurgitation, where ejection fraction can still be normal, and yet the contractility of the ventricle might be reduced because the resistance is so low in the context of a moderate to severe mitral regurgitation. Does strain help there?
I would say for that problem, not really. It helps mainly where you have, let's say, subclinical dysfunction, and you will see it like in cancer, chemotherapy. It's recommended today from the European and the American societies for imaging that you should now apply strain imaging when you follow patients undergoing chemotherapy. And the reason why is that ejection fraction has not sufficient sensitivity to pick up all the damage done to the myocardium.
Well, that's an expanding field of cardio-oncology, and in our hospital we just start a group to do this, and so there it might be very, very useful. Of course, then the question is, what do I do with it? Do we have the tools to really treat these patients appropriately? Would you then, if strain shows already some dysfunction, would you sort of in a preventive way start treatment in these patients?
You are right that there is today no randomized controlled trial to document that doing imaging or any other sort of measurement of cardiac function provides added value. But recommendations now is to measure before you start chemotherapy, do LVEF, which is a key measure, and strain, plus ECG and troponin. And if anything is abnormal, the patient should be seen by a cardiologist. And you repeat the measurements after endochemotherapy and do the same, the troponin, the strain, and EF. And if there is a drop in EF by 10 points or more, the value is less than 53%. So if there's a real drop in EF, you are referred to cardiologist, and then the cardiologist will discuss with the oncologist what to do. And that might sort of initiate more repeated measurements. Yeah. But strain, if you have a normal EF and not really a drop of 10 points or not a drop below 50, you look at strain. If a recommendation now is if strain has dropped by more than 15%, you have probably a subclinical LV dysfunction. And again, patients should be seen by a cardiologist, and again, oncologists should discuss it.
What about other situations? Let's say aortic valve disease, like for instance, aortic regurgitation. For quite some time, the ventricle is fine, and then suddenly you have this marked drop, and it's very difficult to reverse that, contrary to aortic stenosis. Would strain tell you earlier than the ejection fraction that there is a problem with the ventricle?
Yes, in particular with aortic stenosis, where you have hypertrophy sometimes, and you may have normal EF, but strain is more sensitive. So strain is an early marker, but today there's no real recommendations to apply strain for that application yet. But it's more sensitive, and if you see a drop in strain, normal value should be about 18 or about 16, depends upon sort of methodology and a little bit how we measure. But if strain is dropped below 16 and you have valve disease, it's a marker that the ventricle is starting to suffer. Yes. But yet it's not into the guidelines. So it will, but I think it will come in the future.
So in your institution, in your echo lab, do you do this in every patient, or how do you use the strain analysis?
In our echo lab, some people use strain and some don't. Some people say we would like to see it in the guidelines. Somebody say I'll be a little bit ahead of guidelines. And so some people measure strain and some don't. So it varies. And one limitation of strain is that, let's say in 1 in 10 patients, it's too much noise in the signal. So strain is not at all a standalone measure for function, LV function. You need the ejection fraction as the base, and you are adding strain to pick up the more subtle changes.
And how is it comparable from one equipment to another?
That has been looked into in detail, and a publication came 1 or 2 years ago from Leuven, Jens Ove Vogt, who assembled a bunch of vendors, and it's good for longitudinal strain. So strain is good as a global measure of global LV longitudinal function. For segmental strain is more variation. But today it's robust and can be measured, provided you have some experience, to measure global LV function.
So we need more studies to actually show the impact in different patient populations, but I think it's a really exciting new technology, and I'll thank you for sharing it with us, and thank you for coming to Davos, Otto.